Everybody ready?
Yeah.
Okay, right then. So, so welcome to the PHU Clinical Academic Hub podcast. My name is Chantal Osler, and I'm a consultant clinical academic, which is essentially a clinician who's working clinically, but also leading research relevant to their specialty. I'm a physio, and I specialise in prosthetic rehabilitation. So with me on our podcast journey today is Rosalind Austin. So give us a wave, Rosalind. Rosalind is a cardiology clinical academic nurse, and so this is the first of our Reviewing the Evidence series, which is aligned to the monthly educational hot topics and is designed to complement the upcoming activities that are going on around that hot topic that you might already be aware of. So we'll be producing a podcast each month, reviewing an article related to each hot topic area, and will be accompanied by the PHU specialist clinician in the field. So today's topic is deconditioning, and our lovely specialist is Hayley Price. Hello, Hayley.
Hi, everyone.
So Hayley, can you tell us a little bit about yourself and anything that you might want to share about what's going on with deconditioning this month?
Yeah, absolutely. And thank you so much for having me. I'm really pleased to be on the first one in the series. So my name is Hayley Price. I'm the Falls and Deconditioning Specialist Physio at Portsmouth Hospitals. So my role actually sits within the patient safety team. I'm a clinician by background, specialised in trauma and orthopaedics before moving into this role. And one of the things we're really trying to build at the minute is an awareness of hospital-acquired deconditioning. So very excitingly, this month across the whole of the trust is Deconditioning Awareness Month. It's a huge trust-wide educational learning theme, and we've not done it before, so it's fantastic we're getting it out there. It's such an important topic. It spreads people across the whole trust, and this is a really good way to start sharing the evidence around it as well.
Fantastic. So today, Hayley has chosen a paper for us to review titled Interventions for Reducing Hospital-Associated Deconditioning, a Systematic Review and Meta-Analysis. And we're going to put the link to the paper below so that you can find it if you want to have a read. So this is a systematic review. So we're going to use a critical appraisal tool, which I have here, to guide us through the process. And there are many different tools online for critical appraisal. And throughout the series, we're going to use different ones. But today, we're going to use the CASPER, Critical Appraisal Skills Programme for Systematic Reviews, and which we'll also put the link in below so that you can have a look at that. So before we start, we're just going to ask Hayley just to give us a brief summary of the paper for anyone who hasn't read it yet so that you can follow along. So I'll pass over to Hayley.
Thank you. So I picked this because I thought it was because it's a systematic review and a meta-analysis. And just to give you an idea of what that is, I'm sure Chantal and Rosalind will jump in if I get anything wrong. But systematic review looks at taking, gathering and appraising and summarising evidence to answer a specific question. And then the meta-analysis side of it is a statistical procedure of taking numerical data from multiple different studies and then looking at that together. So I'm hoping that's right. So the main question that we wanted to answer, or what this paper is trying to answer, is to determine the effectiveness of hospital-based interventions that are designed to reduce hospital-associated deconditioning, or HAD, for people in an inpatient hospital setting. Now, this paper was based around adults, and again, in that inpatient setting, so not people at home, which is really key. I chose that one because obviously we work in an acute trust, so that is the patients that we are dealing with. When we are talking about our trust, we tend to very much split paediatrics and adults, so we're just talking about adult care, which again is why I picked this paper. I also picked this because it's about interventions, and the question I get asked a lot out on the wards is, what do we do to prevent this in our patients? So this seemed like the perfect place to start to try and give people an idea of what's out there to try and answer this.
Fantastic. So Hayley, can you summarise for us a little bit about what the authors of the study felt were their key findings, and then we'll go on and critique the paper and decide whether we think those findings are relevant, are true, and how much confidence we can have in them.
Yeah, absolutely. So they looked at, I won't go too much into the kind of analysis of it because we're going to do that, but just the conclusion was they felt that enhanced inpatient programs which were targeted at reducing hospital-acquired deconditioning may have some benefit over usual care in an inpatient adult setting. to be clear. They did sort of say that there's low quality evidence, but we'll come on to that later. But ultimately, it may have a benefit.
Okay, fantastic. So if we get started now, we will use the CASPER tool. And so the CASPER tool from the Critical Appraisal Skills Programme comes with 10 different questions. And so it starts with section A, which has 2 questions, which help us decide whether we should even continue reviewing this paper. And then each of the questions has a couple of hints alongside it. So we're going to work through them, and I will read out the question and some of the hints. And then the lovely ladies here can help answer this question and give you some information about how we might work through this tool and what the review of this particular paper is. So question number 1 is in section A, which is about, are the results of the review valid? And question 1 is, did the review address a clearly focused question? And so that's thinking about, is the issue focused in terms of the population studied, the intervention given, and the outcome considered? So what do we think?
I ticked yes for this one. Yeah, absolutely.
Don't look so nervous, Hayley. You're not being graded. This isn't an assignment. I agree.
Yeah, I
agree. It definitely had a really focused, really well-defined research question that made it very clear what specifically they were examining. So 100%.
Yeah. And so when we I was looking at it in terms of perhaps using the PICO framework to help go through the population, the intervention, the comparison, and the outcomes. And so we could say for the population that it was very much adults in inpatient settings, and so that was Hayley's mentioned that was really relevant. The intervention was a bit more tricky to define in that there were lots of different interventions, and we didn't know exactly what was involved in some of those interventions. The comparison was also quite tricky because it mentioned usual care, and myself and Rosalind were talking about this morning, that it was really hard because to know what the usual care was, and it wasn't particularly well defined in this paper. And then the outcomes we will talk about a bit later, but they very clearly set what their outcomes were that they were looking at in the paper. So the next question is, did the authors look for the right type of papers? So the best sorts of studies would address the review's question, have an appropriate study design, usually randomized controlled trials for papers evaluating interventions. So what do we think?
Yeah, again, I've put yes for this. So what I found that they included, so they looked for RCTs and non-RCTs, which I thought was really good. And in the end, they ended up including 5 RCTs and 2 that were non-RCTs, so randomized controlled trials. They looked at published and unpublished data. They looked at kind of what the current research is that's going on, see if they were missing anything. They covered lots and lots of databases. So yeah, I thought they did really well. Their inclusion criteria was really clear. Yeah.
Yeah, Rosalind, anything you want to add?
So the only thing that I would probably add to that is, especially in one of the results they were looking at, one of their outcomes was around psychological impact. And so one of the things that I felt that they missed was they didn't include the PsycInfo database, where a lot of those sorts of research studies would have been included. Now, whether or not those research studies would also have had the other outcomes they were interested in without going through it yourself, I don't know. So it's still a yes for me, but it's a I wonder if they missed stuff.
Yeah, fantastic. So generally from those 2 questions, we think that it would be worth continuing to review, which is fortunate, otherwise we wouldn't have much to talk about. So question number 3 is, do you think all the important relevant studies were included? And so we talked about just a minute ago about which bibliographic databases we used, and Rosalind quite rightly mentioned that PsycInfo was one that was missing, so that it's possible some papers may have been missed. Did they follow up from reference lists? Was there personal contact with any experts? And did they include unpublished as well as published studies and non-English language studies? So, yeah, so ladies, any comments on that one?
So,
go on, Rosalind, you go for it.
Go ahead. So for me, the one thing that I noticed, so they did mention in their search strategy that reference lists were going to be searched, but then they didn't follow up on that.
So when you say follow-up, you mean they didn't give explicit numbers that were identified through reference lists?
Well, they didn't, I have no idea.
Okay,
that's the point. So they said they were going to do it, but then in reporting it, they didn't say that they either found some or didn't find some. And some of the studies that they excluded were review studies. So it would have been interesting to know whether or not they found like an additional study from looking at those reference lists, and it just was never mentioned again. So that was my one comment, that it looks like they did it, but we don't know what they found or if it was useful.
Yeah, and so it's really important for us to think about that so that we can feel confident that they've included all of the studies that are relevant to this question, in order to draw those conclusions about the current evidence base. Hayley, did you want to add anything?
Yeah, just when we were looking at the exclusion criteria, they also haven't included patients who were admitted to mental health wards, high dependency wards, or critical care wards. Now we know that there's probably a real place for this evidence and research in exactly those areas, especially if we look at kind of high dependency and critical care wards in the current climate. We're just coming off the back of coronavirus pandemic, and a lot of our patients have deconditioned in those areas. So I think there would have been a place to add them in.
Yeah. And so the systematic review, I can't remember what the date was it now when they did their search. Oh, it was June 2020.
Yeah.
Yeah. So it's unlikely everyone was possibly in the middle of COVID then, and unlikely doing all these big kind of rehab trials. But you're absolutely right in that if this was going to be repeated, you might really be thinking about those different settings. So especially in the light of what's happened recently. And what did we think about their inclusion and exclusion criteria for the studies?
Yeah, again, I thought it was pretty good. So they made it super clear, again, like we said before, that it was adults, 18 and over, hospital wards, and they did acute and rehab settings, which is interesting, and elective and non-elective procedures. So I thought that was good. And originally they said they were going to include surgical and non-surgical. So, you know, that helps if we're thinking of our setting here with a whole acute trust with all of those different patients in. So I thought that was really good. The only thing was where they said they'd use patients where they'd specifically identified those at risk of hospital-acquired deconditioning. There isn't actually, as far as I'm aware from the research, an agreed way of identifying who is at risk. So it would just be interesting to know a bit more about how they identified those at risk.
Yeah. That's very interesting. And I think like your perspective as somebody who works in this population really helps, because that was the other thing I was going to say with did all the right papers get included, in that as somebody who's not au fait with this population, I'm like, and it's a really important thing, and to know your own subject area and know what people are talking about in that area, to know whether or not this is ticking the right boxes or if they've missed the complete point. And you, Hayley, would be much better at being able to help us with that.
Yeah. And so one of the important things for doing a systematic review is that you do have very explicit inclusion and exclusion criteria for what studies you are going to include and which studies you aren't, and that you demonstrate which of those studies met the criteria in order to avoid the bias of the reviewer coming in and selecting studies that meet a particular viewpoint. So, and Rosalind, as someone who's carried out a systematic review, is there anything you want to add to that?
So I would say this article did a pretty good job at making that explicit. So in review studies, it is a standard reporting to use something called a PRISMA diagram, which is basically a flow chart of how they identified the studies, when they excluded studies, and why they excluded them. And when it came down to the full text articles and the ones that they looked at, so the 38, they did an excellent job of saying why they excluded them, and all of those reasons for exclusion aligned with either an inclusion or an exclusion criteria, which was really good. For me, I would have liked to know, because they went from quite a big number of 283 down to 38, and there's no comment as to whether or not that was because the search returned spurious results, or whether it was inclusion, exclusion, and whether or not they based that decision, those records being excluded, on just a title, or did they read the abstract? How did they make those decisions? So that for me was a little bit of a weak point.
So thinking about how those inclusion, exclusion criteria are applied at each step within the process. And so, yeah, you're absolutely right. It sounded like it was just applied to reading full texts, whereas it would have been quite simple for them to put in whether that was also those same inclusion, exclusion criteria were applied to the reviewing of titles and abstracts to get that huge number down.
Or was it just the titles that they used and they didn't even look at the abstracts? And so it helps you see whether or not how exhaustive or how inclusive it was and what the criteria was used in order to determine the inclusivity.
Yeah, fantastic.
It's really interesting hearing it explained like that, Rosalind. It's really helpful.
Yeah, fantastic. So then question number 4 is, did the review's authors do enough to assess quality of the included studies? So the authors need to consider the rigor of the studies they've identified. Lack of rigor may affect the study's results, and they've put in inverted commas there that all that glitters is not gold from the Merchant of Venice. There's a little helpful reference there. So what did we think about the author? Did they do enough to assess the quality? So Hayley, do you want to tell us how they assessed the quality first of all?
Yes, so I've written this down, so I am reading this. Apologies.
Yeah, don't worry.
They had one reviewer who independently reviewed all the titles and abstracts from the search result, and then they had a second reviewer who independently verified what the first reviewer had thought. Now, obviously, not being from a research background myself, whether that's kind of normal practice or not, but I think they'd normally have 2 that would do both of those things rather than 1 and then the second one come in. But yeah.
I think there is that kind of that sort of gold standard that you would have 2 independent reviewers. But again, I think as long as you've got more than one person involved in the process somewhere. The other thing that they did was they used a tool called the Cochrane risk of bias tool. And they used that to assess the quality of the study. So they used the inclusion and exclusion criteria to identify studies that they would include in the review. And then they used this Cochrane risk of bias tool to assess the quality of those papers. And that's something that's really important in systematic reviews, is that there's this assessment of quality, and it's done in a standardized way using a recognized tool. And obviously the Cochrane risk of bias tool is quite a well recommended tool for systematic reviews. So Rosalind, do you want to talk to us a bit about that?
So they actually used a second tool as well.
Yeah.
So they used 2 different tools. So they used the Cochrane one, which was about bias, primarily around bias in an RCT. But then they also used something called GRADE, which which was looking at the quality of evidence around the outcomes that research reported. So that includes the Cochrane bias tool, but then it also talks about indirectness relating to similarity in clinical practice, and imprecision around number of participants in the events, inconsistency in effect estimates, and a likelihood of publication bias. So they assessed it quite extensively. Now, for me, the thing I found very, very interesting is that they put a really strong emphasis on bias, and most of the reason for downgrading the strength of any results was around the blinding or lack thereof of both participants as well as the researchers. Now,
can you tell us just quickly what that means, what blinding means?
Okay, so blinding is a research process where the participants won't know what intervention that they are on. It is most commonly and easily used in drug studies. So you have a real active agent, and then they make a pill that looks the exact same, but it just will have like rice powder or sugars or some form of carbohydrate in it. And so like that participant doesn't know what they're taking. They don't know whether it's real or not. And most commonly, RCTs are double blind. So the people who are actively interacting with those patients are also blinded. So they don't know if somebody's on active or placebo. Now, with a medication, that's dead easy to do because you can make it so that the bottles look the same, that the tablets look the same, and everything looks the same. However, it isn't as easy as what you think, even with a tablet. So there are really common side effects sometimes to agents that make it really easy to tell that you're on drug or not. And that's both from the participant point of view and the researcher point of view. Now, it gets much more complicated when you're talking about the sort of interventions that this study is talking about. How do you blind somebody who's getting more exercise than their neighbor? Is that even possible? So one of the questions I asked is, how much was this bias assessment a tick box that they were doing? Because these research studies were much more pragmatic, and they're being assessed against something that isn't the most pragmatic of tools. So how much as a reader I then believe that this downgrading of the evidence is true or not becomes a lot trickier, because without going back and reading the original studies to make up my own mind, is did they do a good, solid, pragmatic study, but it was impossible to blind the people, or actually was it really rubbish? So it's a bit trickier. It's not as easy as what I think they try and write it to be, because they're like, oh yeah, they're all rubbish. And I'm like, but were they?
Yeah.
Were they actually rubbish?
And you think in an interventional study that if they're not blind and they haven't the impact of placebo, so that they think they're improving just because they've had the intervention, does it really matter as long as they've improved?
Exactly.
Such a good question, yeah.
Okay, thank you for that. That was really interesting. So there's some, they've obviously critically appraised the studies, which is a really important step in a systematic review, and they've used two very recognized appraisal tools, and they use them consistently across the studies. However, there's a question about whether the types of study, these interventional studies, whether that risk of bias tool that prioritizes blinding is appropriate, and actually whether the quality of this evidence may be slightly higher than what is presented in these findings. So brilliant. Okay, next question, number 5. If the results of the review have been combined, was it reasonable to do so? So, and the hints that we've got to consider are, were the results similar from study to study? Were the results of all the included studies displayed clearly? Were the results of different studies let me read that again. Results of different studies are similar, and reasons for any variation in the results are discussed. So in terms of what they said they were going to do, they very clearly stated that if the studies if the interventions were similar enough and the outcomes were similar enough, then they would combine the studies into a meta-analysis. But if they were different, then they would use a narrative approach. So they would just describe what had happened. And so they were quite clear about that. But Rosalind, you had some points to make, didn't you, about how they did actually combine those studies?
Yeah, so I think in general they did what they said on the tin, and I don't dispute that. But I think it's really tricky because their inclusion criteria allowed for such variation in the interventions, as well as in the outcomes and the timing of the outcomes. It did feel a bit like we were comparing a bit of pears and apples, because only one study did a 12-month follow-up, and yet one of their conclusions was like, well, this strongly points to the power of this intervention in the long term. And I'm like, but wait a second, that was one study.
Yeah.
So it's a bit of, for me, it's not that they didn't do what they said, because they did.
Yeah.
But for me, in their discussion and their conclusions, I think in a desire to write something that's useful to clinicians, they ended up painting things with a bit more of a broader brush. And I think if you were a busy clinician and you only read the abstract or you only read the discussion and conclusion chapter, you might falsely believe that there's greater weight to their conclusions than actually what this article presents.
Yeah. Hayley, did you want to add anything about the way they combined the results? Or are you like me, a bit like, oh my God, a meta-analysis? I don't know what that's.
Yeah. So that was my initial impression. And I would say to any clinicians out there doing the same, that's okay. But what I did think they did really nicely is they put a really nice table in there, which was a summary of characteristics of the studies. Do you know what? That was super easy read. And just by reading that, you could really quickly follow exactly what Rosalind is saying about, oh, well, one clearly had a 12-month post-discharge follow-up, one had 20 weeks, 3 months. So yeah, taking away some of the other complexities from a clinical head glance, that one table being there was so helpful.
Yeah, and actually that's another real strength that from a systematic review is when they use really good data extraction tables.
Yeah.
And they're able to present to their reader the kind of the breakdown of the individual studies, so then you're able to have a look through and kind of make your own judgments. So that's a real good plus, I think, that the way they've used their tables. Okay, so if we go on to onto section B, and so that's really focusing on the results. So question number 6 is, what are the overall results of the review? So are you clear about the review's bottom line results? What are these results, and how were these results expressed? For example, odds ratios, etc. So Rosalind, you also, again, we're talking this morning, had an interesting point to make about their results.
So for me, I think that they really missed an opportunity in their results, because I think for me, the biggest finding that this paper has is actually one that is really exciting, especially if as a clinician you want to learn more about this and you're interested in doing some of your own research, is that actually there isn't enough studies out there. There's only 7. There are 7 studies that were identified for inpatient interventions, not just in the last 10 years, but ever since the databases began. There were 7. That's nothing. Further, there's only 7 in North America. So where are all the studies from Europe and all of these other places? So was that a problem with their search strategy or whatnot? So to me, the exciting bit is actually this paper has highlighted how little we know, how loosely these things are measured, and how are we even measuring the right things that are important to patients and important to clinicians. And actually, that's the exciting bit, because those 2 things give us so much room to grow and to develop research that will matter to us locally here in Portsmouth to help start improving not just our inpatient experience, but decreasing that hospital acquired disability, so that they don't end up being revolving door patients. And that to me was the conclusion I wanted them to write.
Yeah. And so some of the outcomes that they really looked at physical function, activities of daily living, depression, health utilization in terms of length of stay and nursing home residence, and readmissions, and then mortality. And exactly as Rosalind said, it's like, are those studies measuring outcomes that are really important? And how would we know what those outcomes were? And so we might look at something like whether hospital-acquired deconditioning has a core outcome set. So a set of outcomes that have been rigorously developed. And when I say outcomes, I mean outcome domains that have been rigorously developed, including feedback from patients and expert clinicians as to what are important outcomes that should be collected, important outcome domains that should be collected in every study associated with hospital-acquired deconditioning. So we could have a look there to see if they had, and there's an organisation called COMET that you can have a search for and see if there's a core outcome set. If there isn't, then it's again using some of our kind of background and experience. And so again, their primary outcome was physical activity. And again, that seems like a really reasonable outcome, doesn't it, to be their primary outcome? Rosalind, do you want to carry on with this one?
Yeah, so their primary outcome, they didn't have any. So to me, that raises two questions: is why did they have that as a primary outcome?
So let's go back one step and just say that they had no studies that reported physical activity at their primary endpoint, which was 3 months. Yeah. So they had quite a few studies that reported physical activity, but they reported them all at discharge. Yeah. But they set this primary outcome endpoint at 3 months, and then none of the studies reported on that. So I'll go back to you, Rosalind.
So for me, that question is that, did they ask that question because that's what they're hoping to go on and do, and they wanted to prove that nobody had done it? So question number one. And question two is like Chantal has already hinted at with comment and outcomes that are important, is why the 3 month mark? Why is that important? Why was that set to be the primary outcome? And you know, like what was the point if the finding is that nobody does it? And they don't discuss that, they don't talk about that, they just say nobody does it. Yeah. And so that to me just raised some real questions around, well, if nobody does it, then why was that the primary outcome? Did you not know the literature? Are you laying a foundation for future work you're hoping to do? Like what was the point of that? Because that's very odd to have a primary outcome be 0.
And when Rosalind says that, so she's made a really important point there about, did you not know the literature? Because ordinarily when you do a systematic review, you do scoping searches beforehand to give you a bit of an idea of what your inclusion exclusion criteria might be, so that they can help construct that. And so, but actually when we look in what they documented about their outcome, they don't give any justification for why they've chosen that 3 month period post-discharge. And so Hayley, I didn't know from your kind of clinical background, and the answer to this might be no, but whether you can think clinically whether there might be any reason why they've gone for 3 months.
No, not really. I did think about this. Not really. So coming back to a few things you've said, like we've all said, the research is limited around this. There is no agreed set of things we should definitely be looking for, in the same way we have no agreed way of assessing for hospital-acquired deconditioning. There's some that say, oh, maybe these battery of tests will help, maybe this is a good outcome, but there is no agreement. So that's why we need more around this to come up with that. In terms of the 3 months, I'm not sure. If I think about our kind of rehab settings we have here locally to us, it's not even that a standard stay is 3 months or standard rehab process is 3 months. So yeah, not entirely sure why they've chosen that.
Yeah. So again, that would be something that we would be really highlighted as a weakness of this study. So is that why they've chosen that? And if they were going to do an intervention and they were trying to highlight this lack of a 3 month follow-up, then they could be explicit about it and tell us in the paper, and that builds that justification for why you've made certain decisions, which is really important. It's that underpinning for why you've done what you've done. So okay, so if we move on to question 7, so this question I think is answered by quite a lot of the kind of things that we've talked about before, but it's how precise are the results? And the hint that they've given us is to look at the confidence intervals. And so Rosalind, shall I hand this one over to you? I'll be like, yes, please. Can I please hand this one over?
So I think it's tricky. So when I first started literature review and going into research, I had this impression that statistics were like this. Kind of
like,
yeah, exactly that. I've got my Googled phrase of confidence intervals here, just in case you ask me.
So the confidence interval gets tied to your normality of data and your distribution of data. And there are, believe it or not, and this came as a shock to me when I discovered it, because I always assumed that statistics was math, so it was either 1 + 1 = 2 or 1 + 1 = 0, depending on which system you're using, whether you're using computer math or numerical math. But it turns out that it's actually really philosophical, which is a pain in the bum. Because what some people, and there are schools of thought within statistics that are arguing that actually normalcy isn't that important in confidence interviews. Confidence interval just describes what you're looking at and how, whether or not the data falls underneath a pre-described mathematical expectation of where the data should be. That is all it means.
How confident are you that your data is telling you what you think it's telling you?
Assuming that those tools that you've used are actually telling you what you think that they're telling you, and there isn't confounding factors or things like that. So
everyone finds this mind-boggling.
Yeah.
Oh, it's completely mind-boggling. And like these principles are held up as this like be all and end all. And I think again, like it goes back to what I was saying around the arguments of bias is actually evaluating as a clinician. What were they measuring? How did they measure it? Was it expected, or was it contrary to what they expected to happen? And I think for me, like by the time they stopped fiddling with the numbers, there wasn't very much left. So because of all of the filters that they used around bias and reducing the strength of the studies, they got rid of, like, I mean, they only started out with 7 papers, and they got rid of so much of the data and decreased the power of the data down. You know, to me, I was just left at the end of it going, well, does any of it matter? Because you've said that the data is such a low quality because of those bias issues. What does the confidence interval even mean then? Because if you've already said that the data is rubbish. Yeah. So for me, it had some more, and this is hilarious, more philosophical issues with what they did with the data rather than the math. Because I checked some of their math and it was fine, but to me, it was a bigger question.
Yeah, and linking back to many of the things that we've discussed already.
Exactly.
So. Okay. Anything you wanted to add there, Hayley?
No, absolutely not. I mean, I think I've looked at it less critically as that and gone by confidence intervals, but it's nice to understand the bigger picture of it. So yeah, it's really helpful.
Fantastic. Okay, so question 8, can the results be applied to the local population? And we need to consider whether the patients covered by the review could be sufficiently different to our population to cause concern. Is our local setting likely to differ much from that of the review? So I'm going to hand this one over to Hayley.
No, I think is kind of my first instinct with this one. So we've already touched on it. All of the 7 studies were undertaken in North America. We are not in North America, we're in Portsmouth. So that in itself is gonna change a lot about potentially the population, the settings we're in, and coming back to what we very first started with, what is usual care? The usual care system in North America compared to here is going to be totally different. So I think even if you just look at that bit, we can say no. They also only ended up with all 7 of their studies, including acute medical wards. So although they did include them, there wasn't any studies in those surgical wards, geriatric wards, things like that. So yeah, we wouldn't be able to take that and instantly put it to our local population.
Yeah, fab, absolutely. Anything you wanted to add, Rosalind?
The only thing, like Hayley already said it, and to me the biggest hole in this, and again, it's not the fault of the authors, it's what was out there and what they found, is actually the populations that are highest at risk were either excluded or they didn't find any research. So to me, again, that's something to be celebrated, because that says, hey, we need to do this.
We love a gap as clinical academics.
Exactly.
We've got to get in the gap with some more research.
Exactly. Not dropping any hints, Hayley.
Or anyone else out there.
Absolutely. Yeah. It's an opportunity, not a bad thing. Yeah.
I want to be in that gap. Come and talk to us.
Yeah, exactly.
Okay. Question number 9 is, were all the important outcomes considered? And we've kind of talked about that, really, that although there are some issues with the outcomes, that we don't actually know what the really important outcome domains are that should be important when you're recovering from hospital-acquired deconditioning. Is there anything anyone else wants to add with that one? Is there anything else anyone else would have liked to have seen reported?
Initially, I kept trying to pick holes in this, but I think if you were looking at a purely clinical perspective of what we look at in our patients here, the big ones are function, discharge destination, mortality, and readmission. So if we're just looking very superficially at the big key ones, I thought they covered those.
Yeah, and there was quite a focus, wasn't there, in the studies on things like nursing home residents?
Yeah.
And one study looked at readmission, one study looked at length of stay, but 3 studies looked at nursing home residents as their indicator of health utilisation. Mortality, 3 studies looked at, and then a lot of focus on physical function. So interesting, 1 looked at depression. So yeah, Rosalind, what did you want to add?
I would add that they should have, I would like to see in future research more emphasis on capturing not just mortality as an adverse event, but readmissions as an adverse event, where the studies seem to mainly focus on that around the health economics and the cost. I think actually it's a really important feature, and something that I see in heart failure quite a lot is they have a lot of readmissions, and there is a known relationship around hospital-acquired disability. So if you could show that this intervention promoted reduced readmissions, not just from a cost point of view, but also from like that occurrence point of view, it might give further weight to cost to benefit ratios when it takes time to, okay, are we going to embed this intervention locally, nationally, internationally?
And I think the only other, sorry, Chantal, the only other thing on that you can link it in with, which is something we're trying to do in this hospital at the minute, is look at the effect of preventing hospital-acquired deconditioning on other inpatient complications, falls, pressure sores, those complications. So for future practice, future research, that would be a really interesting thing to look at as well.
So
good idea.
Looking at avoidable harm as a kind of a key outcome. Yeah, that's a really relevant.
That's brilliant.
Point. Yeah, particularly
noted. Just gonna write that down.
Well done, that girl. Okay, so and we've kind of touched on this a little bit. The final questions are the benefits worth the harms and the costs of this kind of a study? And I think probably from this, we don't really know. Like, we can't really tell. We're thinking perhaps not, because with the findings, we're kind of showing that there was very little difference, but we're not entirely sure how much confidence we can have in those findings. So I'm going to jump, just because we've got about 5 minutes to go, so I'm just going to jump to ask Hayley, following the appraisal of that systematic review, what would kind of the implications for your practice be from this work? What would, as a clinician, what would you take away from it?
So I think the first thing that I would think about myself and try and tell other clinicians as well is, just because we don't have an answer doesn't mean we shouldn't be trying to do something about this. And just because there isn't evidence doesn't mean that some of these things don't work. So that'd be the first thing. Don't be put off. Let's still try and do something. I think it's about trying to look locally. So, you know, if I just speak to our clinicians, what's going on your ward? Find out what the barriers are locally on your ward, and how can we address some of those barriers to keeping our patients more physically active, psychologically, you know, active, all those kind of things, and then being consistent with what they do about it and seeing if it makes a difference. So kind of doing that ward-based level quality improvement work to start, you know, the basis of what we do next. And just asking staff to be innovative and creative. And that's, again, one of the whole ideas of this deconditioning month is not me sitting there saying this is what you should all be doing, but going out to the wards and saying, what do you want to do about this? You see this every single day in your patients. What do you think is going to work? What do you want to do differently? I spoke to some really wonderful clinicians, some nurses the other day, who were talking about, oh, well, why can't we use the day rooms more? Well, who said we can't use the day rooms more for socializing, you know, with patients, activity for our patients? You think that's a good idea? How are you going to get there? So yeah, being creative, being innovative, being a bit brave to say, this is a problem, what can we do about it?
Thank you very much. So thank you both, Rosalind and Hayley, for your amazing contributions. And thank you to everybody listening. I'm going to say everybody because I'm hoping there's loads of you for joining for the podcast. All our contact details for the Clinical Academic Hub and for ourselves are in the information below the video. So if you'd like more information on either clinical academic careers, research in practice, or about deconditioning, then get in touch. And we will see you next month for the next topic in reviewing the evidence series, which is falls. And Hayley is going to be back with us.
Can't get rid of me now.
Yeah. So we'll be putting that out on through the educational websites, through the Clinical Academic Hub and social media in the middle of November. So we look forward to seeing you then. See you later.
Thank you so much, Chantal.
Bye. Right, I have absolutely no idea how to stop the recording.
Has Rosalind gone?
Yeah, we've got our next call is in like a minute. But
no worries.
Comms are going to help me edit it, but so they'll take the beginning and the end of it. But it ran so well through. That
I really enjoyed that. Thank you so much.
Right, hang on, stop recording. There we go.
I